Good afternoon, everyone, and welcome to today's webinar. My name is Richard, I'm part of the team here at Kaleidoscope. And firstly, congratulations on having avoided the temptations of the tennis or the cricket to join us on today's digital event, where I think we're going to have a really interesting hour talking about the National Programme for Stroke, and particularly around 6-month reviews. And to do so, we've got a fantastic panel. Thank you so much for joining. Claire, do you want to introduce yourself?
Yeah, my name's Claire Upton. I'm from the Stroke Association. I'm a stroke support coordinator in the Fylde Post in Lancashire.
Thanks for joining, Claire. Sam?
Hi, I'm Sam Stringer, so Programme Delivery Manager for the National Stroke Programme at NHS England and Improvement.
Tracy Walker. I manage rehabilitation services in Manchester, and I'm also the clinical lead for the operational delivery network in Greater Manchester.
Hopefully it keeps you busy enough, Tracy.
It does.
Yeah, lovely. Thank you so much for joining, and thanks again, everyone, for tuning in to today's discussion. This is the first of a series of webinars where there'll be a number of webinars to follow after this date. So if you want to create your own sort of cut out and keep guides to the series of webinars, you can award yourself a gold star for every one you attend. So thank you for joining today. We are recording today's session, so you may well be joining live, or you may be joining from the future. A huge welcome to you on either score. So just to go through the purpose of today. So firstly, it's about understanding that 6-month review landscape in the context of the NHS long-term plan and the National Stroke Programme. If you haven't heard of the NHS long-term plan, in some ways I envy you, but you're probably all aware of the big plan set out for the NHS in England from January. We're also going to look at ways to implement 6-month reviews effectively and hear practical experiences of delivering 6-month reviews. And so we're going to run this very much as a conversation here in the room, but also a conversation with you joining wherever you are. And so there are 3 ways you can join today and you can get involved. So you can use that ask question feature on GoToWebinar, which will look a bit like a question mark. If that isn't working for you, you're very welcome to use email. hello@kaleidoscope.healthcare is the email address. Or finally, we'd love you to join us on Twitter. That hashtag is 6-month review. So 6-month review, the hashtag, please use that. And once again, if you have technical difficulties, don't worry at all. Recording the session, and we will send you a link with the video in after today's session if all of your tech decides to have a day off. So lots of different ways to join in. I'll just remind you who we've got on our panel, just in case you missed it the first time round. So I'm Richard Taunt from Kaleidoscope. We've also got Claire, we've got Sam, we've got Tracy, we've got a lot of people joining. We know that. So again, thank you for your time. And we're just going to start actually by getting a bit of a sense, if it's okay, of who is joining us today. So we're going to have a very quick poll where what we're going to ask you is just if you could take a quick moment just to tell us what your role is with relation to 6-month reviews. So you might be joining us today because you were interested in the topic. That's great, but we're presuming that you've got a particular role in that context. So if you could very quickly tell us what's some of the experience you bring to today's discussion. Is that lived experience of a stroke survivor or a part of a family with someone who survived a stroke within it? Is it as a primary care provider? Is it as a stroke charity? The Stroke Association, of course, other stroke charities are available. Is it from more of a policy background, or have our limited set of options failed to give you a sufficient description of where you're coming from? So if you could fill that in, we'll give you, let's say, 7 seconds. It's probably reasonable. NHS England, Sam, you advise on a lot of performance metrics. Is 7 seconds okay?
6 tops.
Six. Okay, well, probably already use that. So thank you very much. We'll close that poll. Thank you. And let's just have a little look at who's been joining. Wow, so great. Okay, so a lot of others. So a nice diversity there. A nice mix of primary care providers, stroke, lived experience. Very big welcome to you. And some policy background. So this is one of these fantastic topics which does cut across lots of different areas and organisations, and it's great to see that reflected in who's joining us today. We're also just going to move to a very quick second poll, if that's okay, where 6-month reviews in the context of stroke we know happens in some places more than others. And so our second question for you, just before we get going properly, is just whether a 6-month review service is being provided in your area. And if you can think about sort of the area local to you, so if you are, for example, working for NHS England and England is your area, possibly you might just want to think a bit more locally about possibly where you are, where you live, for example. So is a 6-month review service going to be provided? Yes, no, not sure. Again, should we say 5 seconds this time? Sounds okay?
That'll do.
5. Okay, good. Let's do that. Thank you very much. So we will close that now. Look at that, 68% yes, 50% no, 17% not sure. If you come up with 100% yes, we could sort of take the rest of the afternoon off, couldn't we? And say, oh, great, that's fine. Lovely. That's really positive to hear. And so what we're going to try and do over the next 55 minutes or so is both talk to how, if you have a service in your area, how that could be practically improved, but also, if you don't have a service, what are some of the things that you need to think about in getting that in place? Right, I think that's probably more than enough of me talking. We're going to start with a set of perspectives from our panel. Thank you very much indeed. But just to say, if you want to share at any point your questions and reflections, your comments, please do, and we will come to all of those in due course. Again, that Twitter hashtag 6-month review is there for you on your screens. You can also use that ask question feature or email us. All of those at any point are fantastic. Again, if you're watching from the future, if you're not watching this live, that ask question feature isn't going to be quite as useful, but please do share your reflections with us over Twitter whenever you happen to be watching this. Right. That was enough for me. 6-month reviews. 6-month reviews, really important topic. And I think what we're going to start with, if it's okay, panel, is actually from your own individual perspectives. Why do you think 6-month reviews are particularly important? And Claire, do you want to start us off?
Yeah. So according to Stroke Association research, 45% of stroke survivors feel abandoned once they're discharged from hospital. So 6-month reviews are a really important opportunity for stroke survivors to reflect on how far they've come over the last 6 months. They're a great way of identifying any unmet needs they may have. They may have different needs from they had initially when they were discharged. So they may have physical needs initially and they've had some physio support. 6 months down the line, they may be worried more about finances, sick pay may have finished, how am I going to pay for my mortgage, my rent? So there's lots of other needs that can be identified at that point. And it's really important to just say, how are you doing? Often with the first people have seen once they've been discharged from hospital. The physio may have finished 6 weeks after they've come out. So often it's a great way to say, how are you? How are things going? Do you know what's happened? Do you understand what a stroke is? Do you know how to prevent one? Talk through what's happened. Look at their emotional needs, the mental health. If there's a carer involved as well, ask them what they need support with. Fatigue's another big one that's picked up at that point, because they may have been concentrating so much on the physio that later on they can reflect 6 months down the line on other things that are affecting them. Also, it's important medically to look at the blood pressure. How is the blood pressure? Is it high? Is it normal? Do you know what they're taking the medications for? Our blood pressure monitors detect for atrial fibrillation as well, so we can pick that up. Do they know what the medications are for? Do they know what health issues they've got and how to manage them? And it's looking holistically at all the other needs as well, such as environment, housing, equipment, mental health benefits, and making them aware of what's available in the community to support them really to rebuild their life after a stroke. Often it's the first time someone's been asked, how's your mood? What are your worries? So it's a really good opportunity to sit down and listen to their perspective on how they're doing 6 months after the stroke.
Thank you very much indeed. Really nice, succinct overview. Again, that might be that 68% of you with a stroke 6-month review service in your area. A lot of that might be resonating with you. Please do tell us if so. Sam, your perspective. Why are we talking about 6-month reviews? Why is it so important that we start this set of webinars on this topic?
Good question. So we've been building up the National Stroke Programme for about the last 18 months now, working very closely with the Stroke Association. It's been very clear all along that one of the significant concerns, and you heard some sort of statistics there from the Stroke Association surveys, you know, one of the significant concerns is in the sort of post-hospital phase, the variation in care that different patients are experiencing around the country. And we're sure that there is variation in care, but actually the data that we have available on that section of the patient journey isn't nearly as good as it is during the phase when they're in hospital. So 6-month reviews sort of kill 2 birds with 1 stone. So they are an intervention in and of themselves, and you just heard there some of the real benefits that they can have for stroke survivors. And I had the real privilege of joining a Stroke Association coordinator in Liverpool in delivering a 6-month review, and it was, you know, really clear that the impact that it had for that patient. So in and of themselves, they're a brilliant intervention, which also supports some of the other interventions being highlighted in the long-term plan for the NHS. And social prescribing is one thing which highlights, you know, some of the opportunities in communities to combat loneliness and to provide ongoing support for people with long-term conditions of all sorts as well, and much of that can be relevant to stroke survivors. But at the same time, they're also a data collection point, and they're something which can help us nationally get a much better picture of what's going on for stroke survivors, what the variation is, what's being offered, and where some of the gaps might be. And that's obviously true for local systems as well. And I think it can be really important for them to have a better understanding of that. But on a national level, it can certainly help us, you know, back up some of the concerns that we're hearing and understand some of that variation a little better.
Sam, thanks very much. So that nice coming together of, okay, exactly as you put out, an intervention which really works, but it serves a whole range of other purposes as well. And great to hear that you can combine those 2 aspects together. Tracy, thanks so much for joining. Your perspective, why is this so key?
Yeah, so I agree with everything that's been said. Just to add to that, I think nationally we've got really good acute care, and then a huge variation in the community stroke team element. So quite often in areas where you haven't got a community stroke team who should see all patients leaving hospital, the 6-month review is the opportunity to pick people up who've had little or no intervention. Some community stroke teams see people for 2 weeks, 4 weeks, 6 weeks or longer. So at 6 months, we've found it's a really good time where people have reflected, may have you know, needs to be referred on, it may be a time where they're thinking about secondary prevention, lifestyle things, or people may have had nothing and struggling, where you can, it's a good point for me to pick people up and make sure you know, that they're signposted to the correct services. The other thing that we're interested in Manchester and we're looking at is, I think, as well as just the review itself, it's what is the review telling us? So how can we influence commissioning and service development? So what are the unmet needs? So are people telling us they're struggling with transport, or is it smoking? So it's a good time to have a look at actually what is it telling us, and what from this review do we have to do differently in our area? If it's medication, so what are we missing earlier on that all this group of people are having issues with medication? So in Greater Manchester, we're actually auditing unmet need across all the teams to come up with themes. So I think it's a good point for data. Also, at that point, you can compare nationally in your area what your outcome is. So you can compare your modified ranking score at 6 months with nationally, and you can see, so what's different from us, how many people are at home, and you can sort of look at what your input is. Have you got a stroke team? Does mine look better or worse?
Yeah. So
for me, data's a big one. How we use that now, what's it telling us? Not just a tick box for 80% of reviews of complete. So
Tracy, thanks very much indeed. Yeah, data coming through really strongly, and also Tracy, really clear that for a 6-month review to be successful, it's that holistic review. It's not just looking at a medical need, it's a whole range of different needs. Lovely. Thank you very much, panel, for starting us off. Questions and comments already coming through, so thank you to everyone playing along at home. Just to remind you about how you can get involved, we welcome comments and reflections throughout, whether you want to do that through Twitter, hashtag 6monthreview, use that Ask Question feature on GoToWebinar, or that email address again, hello@kaleidoscope.healthcare, and we'll come to those questions in due course. But I think we'll move on, if that's okay. I think we're going to try some quick fire questions. So what we're basically going to do is throw questions at you, which you could dedicate a 3-day conference to, and see if you can respond in about 47 seconds. So we'll see how we go with that. Sadly, we lack some sort of big gong or klaxon. So what I might do is just take some big surreptitious drink if we're running behind time. But we'll do some quick fire questions here, and then really welcome your questions. We'll come to those in just one moment, if that's okay, panel. We'll see how we do with the time. So Claire, start with you. And sort of you touched on this a bit. What difference do you think a 6-month review makes for a person affected by a stroke?
It makes a huge difference. People are insured, they're not forgotten about. Often people will say, thank goodness you've been, I've not seen anybody, I've just been forgotten about. People still think the GP is going to come and see them once they've had a stroke and they're at home. So it also gives the stroke survivor time to reflect on the last 6 months. What goals have they worked towards? Where do they want to go next? What new goals do they want to set? Give them time to listen to them, be listened to, let them feel valued as the expert of what their issues are after their stroke, and then look at meeting what those needs are that they've identified. It's time to raise awareness about what's available in the community. So if they want to improve their exercise, do they know where to go to do that? Do they know what longer term support's available? They may not have been ready to engage at the beginning because they've got too much on their mind, having just been discharged from hospital. But by 6 months, they may be feeling ready then to actually look at the longer term plan and where they want to be and what they want to do, especially if they're working age and they want to return to work. Benefits is a big one that we come across at 6 months, because sick pay does finish at 6 months if they're lucky enough to get it and they're not self-employed. So often signposting them, referring them into somebody that can help them with the benefit form, because it's so overwhelming for people to do them. But it enables them to reflect on where they've been, where they've come to, and obviously looking at the other medical issues as well, the blood pressure, atrial fibrillation, medication, those kind of things, because basically we want to prevent them from having another stroke and moving forward with their lives.
Okay, thank you very much indeed. And I've just realised I didn't actually introduce you. Some people might have been wondering what on earth this strange sweetie jar is here. It's actually for our Kaleidoscope digital events. It's our jargon swear jar. So we do ask our panelists that if we slip into jargon or acronyms, you do have to contribute. I think we're doing pretty well so far. Sam, I'm amazed that sort of coming from an NHS England background, you haven't so far involved there, but there's still time. And actually, I think this next question might even require it. So Sam, why was the 6-month review chosen to be a national sequin? I'm going to have to put money in for just saying sequin, and Sam, you might want to help me out by explaining what a sequin is.
So a sequin, and I won't go into the acronym, but a sequin is just a scheme that is focused on routine care that we know should be provided, but where we know there is currently some variation. And what it does is it takes a very small amount of that provider's total payment for the year, and it links it to whether or not they're providing that element of care. So we chose 6-month reviews because we knew there was something, which should be routinely provided. We know there's some brilliant practice out there where this is going on. And we also know that it can be provided as a very cost-effective intervention. And there are patients who will appreciate having a letter through the post and getting the time to go through, a set of questions in their own time, as well as ones who will appreciate, being supported with a face-to-face supportive consultation and being contacted over the phone as well. But we also know that that there's a lot of value that can be added, and you're hearing from Stroke Association here about some very holistic and supportive ways that 6 months reviews can be provided, and we certainly want to also draw some attention to that and highlight the opportunities to improve the overall benefit that can come from delivering 6-month reviews.
Great, good. Commissioning for Quality and Innovation, possibly.
There we go.
If anyone wants to correct us on our acronyms, please do. Sam, so I think key point there is that there's lots of things which could be a national secret, but 6 months review is seen as a particularly high impact intervention. Yeah,
particularly high intervention, and obviously stroke really rising up the agenda for the NHS, being prioritised in the long-term plan, made this a real priority.
Excellent, great stuff. Tracy, really encouraging at the beginning there, 68% of people saying stroke 6 month reviews in their area. How do we increase the number of people being offered and taking up a 6 month review?
Yeah, so from my experience, the way the different models are at the minute, you could be the Stroke Association provided that, or a community stroke team. So it's important to make sure that you get all the patients coming from the acute transferred over on SNAP, which is no mean feat. So my
Tracy, SNAP. You're gonna have to look. You have to put money in the jar for that and explain what you're talking about.
It's the Stroke National Sentinel Audit program. So it's where our national audit where we all input data. So a patient comes into hospital and we all audit what we're supposed to be doing, and then when the patient has been discharged from hospital, the record gets transferred to a community stroke team or nowhere if there isn't any rehab, or the 6 month provider. So it's very important for the acute, the community stroke teams, commissioners and the provider of the review to meet to discuss a system to ensure that all patients' records are transferred to that 6 month provider so nobody's missed is a big key thing. There's also tips as well for making sure that the community stroke teams have locked their record at 6 months and sent it off. Otherwise, if you complete the 6 month review, you can't lock it and send it to be recorded. And ensuring out of area, people who move out of area, that the record's revoked and sent on to the correct team. And making sure, another big one is that it's 6 months post-stroke, not post-discharge. So you've got a window of 4 to 8 months to lock and send that record. Anything out of that, then your data. So these are all things that will make your percentage of patients lower and lower down. So it's really important, if you're providing it, to get all those people in a room and work out an effective system.
Lovely, and a lot of that, Tracy, is in some ways getting the basics right, just making sure the information is passed on. Tracy, thank you very much indeed, and thanks again for everyone sending through a whole host of questions, which is fantastic, and we'll come to those in just a moment. Claire, to come back to you, we've already started to talk about this. What are the issues and needs which you see coming up time and time again in 6 months? You talked a bit about benefits before. There's quite a range of things which
that's the biggest one really, is benefits. So it's not just about high blood pressure, atrial fibrillation, whether they're on dual antiplatelets. That's another thing that we pick up sometimes, if they may have been started on dual antiplatelets at first from hospital and should have stopped taking both. We ring that through to the surgery, so then they can get that looked at. And then also, if they have got high blood pressure, then we can ring that. They get seen within 2 weeks at the GP to, because it's really easy to lower your blood pressure, but also tell them other ways how to do it. Reduce your salt, reduce your alcohol. Do you know how many units are in what you're drinking? Do you know about your smoking and why it's stroke related? So it's self-management as well, and secondary prevention. Have you lost weight? Have you gained weight? Do you know how to gain weight or lose weight if that's what's needed? Do you know where to go for your exercise or how to approach that? It's often mood comes up as well, emotionalism. So some people are a bit teary at this time, don't really know why. Fatigue is a massive one as well. I'm 6 months down the line, why do I feel so tired and lacking of energy? They've never heard of post-stroke fatigue. So just that reassurance and information about that really helps. But yeah, we work with a lot of working age people in our area. So benefits is one of the biggest issues, because people really struggle to do the physio and exercises when they can't pay the rent or the mortgage, or how am I going to feed my children? So once you can get that on the way to being sorted, they can then focus on other areas as well.
And that reassurance of you being able to say you're not alone, other people are struggling with this, or trying to work out the best way to deal with it as well.
Yeah. Other issues we've had is, so I've worked with a 64-year-old who wasn't feeling good physically and mentally. Various phone calls to and from the GP. Well, it's stroke related, it's your stroke, but actually he didn't feel listened to. So we went out, did a 6-month review. We could summarise the issues he was having, send that over to the GP, get an appointment for him to be seen face to face. And since then, everything was sorted. We'd highlighted he'd been hearing voices, was low in mood, self-neglecting and falling. And as soon as we'd done the review, sent it over, he had the mental health team involved, district nurses took his blood, and he just said, things have been moving now because you've been involved and highlighted the issues. He then got a diagnosis of vascular dementia, so things started to get done, and it was almost like we needed that review to get him listened to and get those needs met for him so they can get on with his life.
Lovely. Really nice story, Claire. Thank you. And again, if people have similar stories which they wanted to share, please do. We're going to continue on, and again, thank you for everyone's questions they come through. Sam, let's come back to the CQIN, Commissioning for Quality Innovation, the national incentive. When and how will we know if that's been successful? Sort of, will 6 months review still be delivered once the CQIN period ends? If you take this away, does everyone stop doing it? Can you talk us through some of how that's going to work?
Yeah, so obviously, the easy answer is, well, there'll be some data on SNAP on the audit program, and we'll be able to see some change in that, which I'm confident will happen. But obviously, on a more local and on a more personal level, you can see that there's a lot more that underlies that data, and there's a lot of quality that we'd like to see going behind that as well. And I think local systems need to build up their understanding of what's happening there. We won't have all that detail on a national level. But I think, absolutely, this is not something which needs to happen for a year. Next year's stroke survivors are obviously just as important. Yeah. And we certainly hope that that this will increasingly become routine practice where it isn't already, and that providers will see the benefit and be keen to carry on delivering this in the years to come.
Sam, thanks very much. I mean, again, Tracy, we're back to talking about data. Can you talk us through a bit? So it's obvious that inputting data into that audit program is sort of really helpful. Can you talk us through sort of how that information can best be used? What's what you've been doing locally about how you use that data to improve care?
Yeah, I mean, I think it's really important that it's an assurance, isn't it, an accountability to commissioners that what we are providing in acute and especially in community and at 6 months. So we're able to map the whole pathway with dependency and what's the patient's had and where they're at the end. So we can start maybe then looking at what we're putting in is, what's the outcome. But I think one of the things we're doing in Manchester is my big question. So that's fine, we're doing them, but what is it telling us about the unmet needs? So in Greater Manchester, we've got a pilot project where all the 6-month reviews which are completed, we're auditing against the Greater Manchester assessment tool, which just has a whole load of questions like Claire's mentioned about transport, lifestyle, mood, and then we're looking, each team then will be able to look every month and a 6-month snapshot of what were the issues for people living in your area. And on a Greater Manchester level, we can look to pick up themes. So is it transport, is it medical, like I said, is it mood, and is it, and we've also got outcomes on there. So what have you done, so we can understand what we are providing, what support we're providing at 6 months, things like information advice, do they need a community stroke team, is it the GP, voluntary sector? So we're starting to build a picture for me about what the information's telling us. So for stroke patients is an issue at 6 months, and then we can do something about it.
Lovely. And then Sam, I presume that there's similar work going on nationally to look at those themes which are coming out all over the place.
Yeah, and I think another benefit of this CQIN is that in the NHS we're increasingly moving towards integrated delivery of care, and that means between acute and community providers and between the community and the social care sector as well. and 6 month reviews sort of sit in the middle of that. So they're a real bridge between, as well as an important data collection point. I will say that that may provide some challenge to those taking part in the sequin as well, because it does mean that realistically, to understand their data, they're going to need to collaborate. Certainly, if you're a community provider with the acute trust in your area, and actually the sequin will be assessed on the proportion of patients in your area who are receiving 6 month reviews, who've had a stroke 6 months previously. Not the amount of patients referred to your specific team or service that are receiving 6 month reviews. So of course, that means that providers need to work with acute trusts in their area, if they're not the acute trust, to ensure they are getting all the appropriate referrals that they need.
Collaboration being the key, as so often is the case.
Absolutely.
Thanks all. So a last question from me before we go to a whole host of questions we've got coming through. So when we did that quick poll at the beginning, it's still clear there are some areas where there is no access to 6 month reviews. So it'd be great to actually get all of your views on this one, if that's okay. So what would you say to local providers and commissioners in areas where there currently is no access to 6 month reviews? Claire, can you start?
I'd say stroke survivors are being failed, that it's a missed opportunity to ensure the needs are being met, and to enable them to rebuild their lives after stroke, given the stroke survivor and the carer the tools to self-manage and access longer term support, which in the long run will reduce impact on the NHS.
And you say that very politely, Claire, but I can hear the sentiment behind it. Sam?
So I'll take a leaf out of Tracy's book and ask them a question back, which is, what is the quality of care being offered to stroke survivors in your area? What are their unmet needs? What's happening to them within the first 6 months of their care, and what services are they being referred on to after that?
Which they'll be able to give you chapter and verse on that.
Well,
maybe they would have.
If they don't have the answers, then perhaps there's something they could do about that.
Lovely. Tracy?
I think kind of internally, if you're a provider and it's not being provided in your area, then you can go by, we've got networks, we've got an operational delivery network in Greater Manchester, and you've got strategic clinical networks. You can go and find key people to get together with commissioners to say, this is a sequin, and what are we doing? Hold somebody to account for it not being, and try and do that internal pressure.
Tracy, thanks. And I'm just saying that, picking up on a question too from Mark. Mark, thanks so much for the question. Is there an issue that some commissioners just aren't even aware of 6 month reviews, of the need for them or their importance, and sort of something needs to be done just to get it higher up there, priority list?
Well, I think if you think about the pathway coming into the hospital and out, the 6 month reviews here, in the middle you've got the community stroke element of rehab, which is not funded in every area, obviously money. So so some areas are trying to get this bit right first, making sure we've got community stroke team to follow people out, because hopefully at 6 months to give you a very good feedback about they're doing well and there isn't many unmet needs because they've had a really good post-discharge care. So I think the commissioners are aware of it. It's about, for some, I feel, prioritising. Like the Stroke Association often say, it's the cherry, that's the icing on the cake. So actually the whole thing is a package.
Yes.
But it's being picked off at the minute and funded in different timescales.
Lovely. Thank you very much. I think that's the end of our quick fire round, and I think we pretty much kept to time. It did make me incredibly self-conscious whenever I wanted to have a drink that I was going to send some signal that needs to speed up. But thanks to those who have sent through questions already. I will just remind you again of what you need to do if you want to send some through. I will say now that if we aren't able to answer your questions in our allotted time, then we will come back to them and we'll find a way to respond so that every question is answered. But those 3 ways again are: you can come to us via that Ask Question feature on GoToWebinar. You can email us, hello@kaleidoscope.healthcare. You can tweet using hashtag 6month-review. If you are joining later on, please do continue to share reflections through Twitter, although we may struggle to answer your questions unless we can somehow predict them now, or other people might have asked them as well. And so we're going to start, if it's okay, with just a few sort of practical questions. And so people are sort of asking some of the nuts and bolts about the delivery of 6-month reviews. And so I wonder, Claire, if we could start with you, and also Tracy, you might want to come in. So Helen, thanks for joining, Helen, saying how long does it take to complete a 6-month review? Diane saying, how does Tracy's service provide 6-month review and who carries them out? Peter saying, should we develop or do we have a national template for 6-12-month reviews? Do we have standardized advice to offer about lifestyle factors, including sleep, activity, diet, and so on? Should we start with those? Claire, do you want to come in first, and then Tracy? Some of the nuts and bolts about how long this takes and who does it.
So the Stroke Association in our area deliver 6-month reviews in Fylde and Wyre, and more recently Blackpool as well. So we give ourselves an hour and a half for the whole visit. However, it depends on what the needs are and how complex they are. Some people may have no needs. Hopefully they've got no needs, and I would say 40 minutes, especially if we've not seen them before and they need the stroke prevention advice and things as well. But some people, it can be an hour and a half. It just depends what the issues are and what they want to talk about as well.
Okay, and in terms of who carries them out, who delivers 6-month reviews?
So nationally, you can have a look on the SNAP report, and it actually tells you what percentage of the country who the different people carry them out. In my service, we've got a community stroke team. We see everybody coming out of the hospital, and our band for rehab assistant practitioner does a clinic once a week, or she does home visits to people in nursing homes as well. So everybody comes in, they have the rehab, and they go onto the 6-month review list, and they get seen by a rehab band for in my service.
Okay.
Across the patch, it can be normally Stroke Association or community stroke teams, I would say, are the main providers, but it ranges as to what level and grade that person is.
Okay, and Sam will come back in terms of this, whether there should be national templates for this. But a question from Nikki, just picking that up, Tracy, in terms of what profession do the panel feel are best placed to carry out a 6-month review? Diane asking, is there any national benchmarking around who should carry out 6-month reviews, i.e. doctor, nurse, healthcare professional? Tracy, this is your chance to sort of put a line in the sand and say it must be this person, or possibly.
No, I mean, as far as the tool question, there's different ones. There's a greater, I'm going to say Clark then, and put money in the.
Well, you said Clark now. Come on.
The Manchester the Collaboration for Leadership in Manchester, Clark. I've got a GM SAP tool, Greater Manchester 6-month review tool, which is very good. And it's on the website, which people can use. There's various other ones. As there isn't any evidence around at this moment about who does the review best or what is the best method to choose. So, you know, it's down. There's a range of people, but you have to remember it's not actually. So it is a review, and you're asking questions of people. I know somebody said, do you have to be a nurse and qualified? Because you're just asking the questions, and sometimes the fact you're not a nurse, they might be a bit more open, and it's just around training around blood pressure and those things. So there isn't an answer to that question.
Topic of hot debate, Sam.
Yeah, so you know, and would agree very strongly that I don't think we should look at professional boundaries and certifications on this. I think it's something that can be delivered by a range of people. Obviously, these can be done through the post. I think, you know, you get much more benefit from having, in most cases, you know, a face-to-face consultation for the 6-month review. And I think someone with appropriate skills to deliver it, and that's, you know, as vague as it should be.
Okay, and the point about should there be a national template saying this is how you do 6-month reviews, is that something interesting to considering? Do you think there's a need? Talking about there's already tools existing, is there a missing piece here?
So the data set that goes onto SNAP, the audit program, is you know, a pretty small set of data, which is being, you know, mandated from the centre nationally, that everyone needs to be including in a 6-month review. In the guidance that we've put on our website, which we've co-produced with lots of others involved in the programme, there's some more guidance there around what could be used, and that links to some of the different tools that are available to deliver it. But I don't think trying to tell each area exactly what set of questions they should be asking is necessarily the way to go.
Claire, do you agree? Are you just waiting for NHS England to tell you what to do, or do you feel you've got access to a sufficient range of tools at the moment?
What do you use,
We
Claire?
use a GM SAT tool as well, and it's a great holistic tool. It doesn't just look at what medication you're on, what your blood pressure is, if you've got atrial fibrillation, whether the SNAP questions about whether you've had another stroke. It looks at everything, the environment, carers, mood, mental health, memory. So I'd say it's a really good tool in looking at holistically at everything in that person's life.
Lovely, and a couple of questions coming in around nutrition as well. Is nutrition part of the...
Yeah, so we ask them if they've gained weight in the last 6 months, lost any weight in the last 6 months. We can work out the BMI on the chart from the height and weight. If we need to, then we do the MUST tool, then we can refer into dietitian or weight loss management programs at the local YMCA or whatever it is they may need. So we do, the tool does look at everything, but we always start at what's important to them rather than a tick box of question one. We will say what's happening for you, what do you want to talk about, and then guide them around what we need to know as well and fill in the other questions. Because sometimes if you don't ask a direct question, they won't talk about it or won't think to talk about it. So it's a mixture of being person-centered and holistic, and then asking the questions that you need to know definite answers to as well. And
comes back a bit to our discussion about, thanks Claire, about sort of the skills required, that it is that how you adapt what might be a standard template to a particular individual.
And I think one of the benefits of the GM SAT tool, it's got an algorithm to what you would do. So if somebody's asking Magdalena about referral to dietitian at that stage, every area is different as to what access they have. They might have a community stroke team or might not, but at that point it will trigger you to, on the algorithm, to refer to somebody. So that's helpful in the tool. I do think it would be helpful to have a standardized tool because I think but I could understand the reasons why you don't want to tell everybody to do and give people autonomy. But I just think it helps to standardise and equity and making sure that the reviews are a good quality. So I can see a helpful side to having a national tool.
Tracy, thank you. Look, well, this is deliberately designed to be a conversation and a debate, so we all just agreed. But I think, well, let's follow that up. If you're using Twitter and following along, again, that hashtag just at the bottom of the screen, 6 month review, do let us know your view on that particular topic. Do you think that actually there is a space for more standardization, more national tools? Well, if you say yes, I think it probably just doubles your workload, Sam. So if you're wanting that to happen as well, you know what to say. So we might well come back to that in a later bit. But let's change topic slightly. A question from Jen. Thanks for joining, Jen. One for you, Sam, saying even though a sequent is a good incentive, what's the consequence of not fulfilling the needs of the contract in terms of delivery? Is a 6 month review classed as an optional extra by some health providers? Is this incentive good enough?
So I think let's go back in history, 71 years.
We've got about 15 minutes.
Okay, I'll be quick. But the NHS is dealing now with a set of patients completely different to the set of patients we were dealing with when the NHS was set up. An increasing ageing population with an increasing number of long-term conditions, multimorbidities, so multiple different health conditions needing attention and needing ongoing support. And I think historically sometimes rehabilitation has been seen as an optional extra, and I think sometimes assessing and meeting mental health needs has been seen as an optional extra. I obviously don't think that's appropriate going forward, and I think this sequence speaks to that quite strongly. Obviously there's a bit of a carrot and a stick that comes with the financial element of this, but in the future as well, local commissioners will, and it often tends to be that once something has been picked up on in a sequin, local commissioners will start to pay more attention to it in their discussions with providers as well, and I certainly hope that it will continue to be prioritised.
Lovely. Tracy, Claire, to come in on it. Is this new incentive going to be sufficient, or is there some further things that need to be done to sort of, again, increase that uptake, but also increase the quality of the reviews?
Yeah, I think we still have to, you know, with the providers and the Stroke Association pushing areas through networks to ensure that it is picked up and who's taking responsibility for that. In your area now, do the commissioners know it is a sequin, and who on the which hospital or provider is that money attached to in your area, because they're going to be the ones who will need to know this information. So still thinking the networks, community stroke team, Stroke Association to push to make sure it's done. And so it's only for 2 years, is it, the sequence?
This is 1 year.
1 year. So then after that, then it's, you know, to push that it's continually funded.
Okay. Sam, is it going to get extended after 1 year? Is it definitely just 1 year?
Don't know. I suspect it will be just 1 year, but it could be extended. I think probably just also worth sort of plugging and mentioning that within the national programme, we're going to be looking at some rehab pilot projects for stroke. We know that there will be certain baseline provisions which systems will need to have in place if they want to be considered to be taking part in those, and we know that will include, you know, a good quality of inpatient rehabilitation, early supported discharge, but certainly 6-month reviews as well. So we know that there's other opportunities which will be available in the future to areas that are delivering these really well.
Lovely. Thank you very much. We've got, as I said, about sort of 30 minutes or so left. A couple of questions for you, Claire, if that's okay. One, just picking up on talking about, it's about 90 minutes to take a review. How much?
For a complex one.
For a complex one, but then it'd be nice to hear your views on then how long does it take just to input all the data? So let's come back to that one in a sec. But then Harriet, thank you for joining, Harriet, saying, what are responsibilities in following up on needs that are raised, e.g. medication issues? Do we signpost to their GP, or are we supposed to contact the GP on their behalf? So one question just about, again, the time and the data bit, but then actually what happens with all this information and where do those responsibilities sit? Okay.
So as I said, it's a simple one could be about 40 minutes, more complex about 90. It just depends how many needs they've got. They're usually less if they've been seen first early on after the discharge. So what we do is we type it up into a review summary on our database. We send a copy of that to the stroke survivor, and we email it to the GP surgery as well. So it has things for them to, it lists the needs, then it has things for them to do as a stroke survivor, things that we're going to do, and things the GP needs to look at, and then it's got a GP summary at the bottom, which is a really good way of saying these are the issues that have been happening. We don't tell GPs what to do, we suggest, would you be able to monitor the blood pressure? So if atrial fibrillation has been detected and they're not known to have it, then we ring the GP surgery that day, and then they're usually brought in for an ECG. Often.
Come on. Then acronym ECG.
Electrocardiogram.
Okay, good.
So then some people will then go on to be medicated with anticoagulants, which can then prevent a further stroke. So if the blood pressure is high, it depends how high it is. If it's really high, then we will contact the GP that day. We try and get them to do it if possible. If we think they've struggled, they've got aphasia, then we'll do it for them. Otherwise, they see the GP within 2 weeks for the regular blood pressure check as well. If they're on dual antiplatelets, then we will contact the GP surgery that day as well to say, should this person be on these 2 medications? Usually if it comes back they are, it's because they're under cardiology and they've been put on it on purpose. Often it's, we were supposed to take aspirin as well for so many weeks and then drop it, and they just didn't know. So usually we act on things straight away, but it can take a little bit of time to type that all up and then send it off. But it's so good for the GP and the stroke survivor to have a summary of all those issues, who's doing what about those needs and how we're going to meet them, so it's there in writing for them as well.
Lovely, Claire. One very quick further question. Kate, thank you for joining. Kate saying, for voluntary sector employees carrying out 6-month reviews, is there an accredited course for this?
So we were trained internally by the Stroke Association. So we were trained on how to check blood pressures, how to do the assessment, how to use the tool, obviously how to use our database and type it up and record it. And obviously through our work, we know what's available in the community, who to go to check your benefits, who can provide local exercise. We've got lots of information and advice on just about everything to do with stroke, what's happened, why it's happened, how to try and prevent another one. So we're pretty much equipped to deal with most things, or signpost or refer into others if needed.
Sam?
But I think part of the answer to that is no. And perhaps that's something that could be considered. We have the CEF, which is the Stroke Skills and Education Framework. I saw you reaching for the jar, and it might be, there might be some watching this webinar who'd be interested in considering review of the CEF with 6-month reviews in mind.
Lovely. Okay. Good. Tracy?
Yeah, I think you need to make sure whoever's providing that has got the correct training. There isn't, as Sam says, anything national, but whatever tool you're using or whatever checks you have to do, then you should have the training to do that.
Lovely.
At the moment, there isn't any standardised training.
There's point about standardisation coming up again. It can welcome people's reactions via Twitter and other methods on that. We just have well, 9 minutes left, and we'll do some closing reflections. So just a couple of final questions. A question for you, Tracy, which I think you alluded to earlier. A question from Helen. Thank you, Helen. Saying, can you pull reports from the GM Greater Manchester tool that you are using to look at trends and common issues with stroke survivors?
Yes, so Chris at the Operational Delivery Network in Manchester has just designed a simple tool, Excel, which the teams input. So you just put across if an unmet need and who you've referred to and a bit of other data. And then at the end of the month, so that's monthly, and then a 6-month data set. So you just click on the tab for June, and at the end of June, you'll have all the charts to tell you what the unmet needs were, who you referred to, and a bit of background, male, female, MRS scores. And then it can give you a 6 months. So in Manchester, we're using all that to put together for Greater Manchester to show the unmet needs. So yes, and it's very easy. So
if someone's watching, Tracy, can we have that spreadsheet, please? Yeah. Can they follow up with you? Can they talk to you about that?
Yeah, they could do, yeah.
Lovely, great, thank you very much indeed. And so one last question from Claire, if that's okay, and then we might move to reflections. Question from Rebecca, saying, can the panel discuss how the review might span health and social care needs? And we've talked a lot about how holistic 6-month reviews need to be. So it's just to be clear once more, it's not just about health care needs, it's also social care as well.
Yeah. My background's actually social work, so I'm used to going out. We do ours at home, people's homes. We go to them rather than them come to us. So we get to see what environment they're living in. We come across lots of different situations: hoarding, poor hygiene, lack of equipment. People can't get out because they've not got a ramp and they're trapped indoors. So just actually seeing the environment, but also asking them about what it is they're struggling with, gives you a really good way of looking holistically at everything, rather than just the medical issues, but also the social needs. We often see people sat upset, they think it's just them in their own home. Well, how can we get you to meet other people that have gone through it, introduce them to other stroke survivors through groups or peer support? So that's another good way of looking at people's overall needs, because obviously when you're discharging from hospital, you don't really know what they're going to unless they have a home visit with an occupational therapist. So sometimes when you go out, there's a lot of other issues being unearthed there as well.
To keep you busy, Claire, thank you very much. We're going to do, Sam, one last question, and then we'll move to some reflections. A question from Sarah. Thank you for joining, Sarah. Saying, would it be a good idea to have a central register of who does 6-month reviews for which areas, so that acute trusts know where to transfer SNAP, again the audit program, records when patients are out of area? Central register, good idea?
I think would be difficult to maintain and keep up to date. I know SNAP are looking at 6-month reviews at the moment and how records are transferred across providers, and it might be that there can be something done to make that a slightly smoother process. within the current sequence at the moment, if a patient hasn't been transferred from an acute trust to a community provider at all, SNAP will automatically link them to the most likely trust. Another reason why trusts are going to want to very sure to link up and make sure they are getting the appropriate patients, and communicate well with the acute trusts in their area. But I think certainly there could be some opportunity to make that process a bit smoother in the future. A central register might be hard to maintain, but I suspect something can be done.
Lovely, Sam, thank you very much indeed. We are fast running out of time, so we've just got a few minutes left. So I will ask my fellow panelists, well, thank you very much indeed for contributions so far. And if one thing was going to stick with you from today's discussion, if there's one insight which particularly stood out, it'd be lovely to hear it. I will go first just to buy everyone some time to frantically think back across our conversation, but also to say thank you so much for everyone who've sent through so many questions. Again, if we haven't managed to answer your questions in the session, we will find a way, possibly through Twitter or on other means, of coming back to all of those so that we haven't neglected none of your particular points. So one thing that stood out for me, glad to come back to where you started, that sort of 45% stroke survivors have that feeling of abandonment, and then just what an opportunity in 6-month reviews pose to have that conversation, and sort of that way into lots of different other areas, but 45% being far too high. And so wouldn't it be lovely if we were back here in a year or in 2 years where we could say, oh, look, that figure's far less. So lots of optimism, but still that starting point is a tricky one to begin with. Should we go Claire and work our way down? Claire, one insight from you.
So I think it's important to acknowledge that it's not just a tick box exercise. Yes, we need to fill SNAP in and it helps design stroke services, but actually what is important to that person, just asking, how are you since your stroke? What's worrying you? Do you understand about this? Do you understand about your medication, what it's for? Some people don't even realise, oh, you're on this for diabetes. I'm not diabetic. They don't know. So we can help them with self-management, but it's about what those needs are, us helping them express those needs and giving them the tool to be able to facilitate meeting those needs as well, longer term.
Lovely, thank you. Sam?
So I'm going to come at this from a completely different and very commissioner perspective, just to contrast here, which is actually reflecting on the cost effectiveness of 6-month reviews. So, to all the academics listening to this, we don't have great research on this, happy to admit that, but we know that it's extremely cost effective to pick up the management of AF atrial fibrillation in the general population, let alone in stroke patients who are at higher risk of a repeat stroke than others. We know that meeting some of the basic social care needs and confronting them earlier on before they escalate. We know that increasing people's mobility in and around their own home and helping restore them to some of their daily activities and activities in their community. We know those are cost-effective interventions for health and social care, and that 6-month reviews are, doing a great job when they're delivered well to meet some of those needs. And while we don't have great research yet, I suspect they're a very cost-effective intervention.
Sam, thank you. Tracy?
I think my thing is to challenge people who are carrying out the reviews to have a look at what the outcome, the data, what is it? What are these reviews telling you about your patients, and to use the information to make positive changes or to question. So not just to carry it out and report 89% completed, but use audit and things like we've done in Manchester to start to take that next step at what are they telling us.
Lovely, thank you very much indeed. Claire, Tracy, thank you so much for your contributions. Again, thank you to everyone who's been joining, whether you've joined live, whether you're watching later on. We hope you've got real value out of it. to say that this is the first of a series of webinars, so do watch this space for further discussions of this type on key elements related to the National Programme for Stroke. We will be circulating a very short evaluation survey. We'd love to hear how you found it today. We've talked a lot about the importance of data, so data would be great if you can come back on that. Would be lovely, thank you. And particularly sort of any sort of follow-up points or areas where you'd like to have more information shared, or future topics for discussions like this, very much welcomed. We have been recorded today. We will share that video so you can share it with all your friends and family, as well as watching it back. And please do feel free to share with colleagues. I think that's that for today. Thank you all once again, and we hope to see you again on a future one of these webinars. Thank you very much. Goodbye.